It's a slide, Chairman.
Okay, thank you, Gillian. Well, good evening, everyone, and welcome to our annual general meeting, which reflects upon the financial year of 2021. It's nice to see so many people present again, and obviously we've got a few apologies. Those apologies are from Paul Foster-Jones, Carol Langrick, Marion Brown, Valerie Johnston. There might be others that have come in or may come in during the course of the meeting, but we'll record them later. The declaration of interest. Any attendee who is aware of a private or personal conflict of interest is required to disclose it at this stage or when the conflict arises during consideration of the item or topic. We'll move on to the minutes and matters arising from the last meeting, which was on the 23rd of September 2020. And if we take any inaccuracies or matters arising on each of the pages as we move forward, starting with page 1. And there's just one omission on page 1. That's attendance at the last meeting. Michael Brederick was in attendance, but unfortunately he's been omitted from the attendance list. So that's on page 1. Page 2. Page 3. Page 4. Page 5. Page 6. Page 7. Page 8. Page 9. Page 10. Page 11. And finally, page 12. We then move on to the Chairman's opening remarks. I've just got a few of them. Obviously, this time last year, nobody anticipated that we would still be in the midst of COVID-19. It's been a very difficult 18 months for everybody concerned in health and indeed social care. We thought by this time it would be over, but unfortunately it isn't, and hence our virtual annual general meeting once again. There's been just one change to the board since our last meeting, and that is Simon Jerry has now moved on to become our chairman director of our subsidiary company, Synchronicity Care Limited. And we're very fortunate in appointing Dr. Richard Scotham as our new non-executive director, who joined us in April of this year. Sadly, we've lost a very good friend from our NHS Foundation Trust in the last couple of weeks, and that is Kate Woolley Brown. Kate has worked in the healthcare for over 4 decades and is well known to the community of Weir Valley, where she worked as a district nurse before retiring in 2011. We were absolutely delighted when she joined our Board of Governors then afterwards, and over the last 2 years she has been our freedom to speak up guardian. This role is significant for the Trust in that it is an independent role where any member of our organisation can speak to Kate privately with any concern or any issue they may have. So it's with sincere regret that we lost Kate very, very suddenly just recently. So our condolences go to Kate's family and all those who worked with her. With regard to staff, I've mentioned about COVID-19. We are exceptionally proud of our staff across the whole organisation, 7,500 of them, who have been extremely resilient, compassionate and caring as always during very, very difficult time. So our sincere thanks go to each and every one of them for what they have done over the last 18 months and continue to do during these very, very difficult times. This AGM, as in previous AGMs, is a reflection on the previous financial year. But we have always taken the opportunity to do 3 things during our annual general meeting. First and foremost, to provide you with an account of our performance over the last financial year, and in this case it is 2021. But alongside that, we will obviously talk about current developments, and obviously COVID, as I mentioned, is top of the agenda. But we will also, as the Chief Executive will do in our presentations later, try and forecast what the situation is going to be like, particularly over this coming winter, where it is predicted that it will be very, very difficult. But we cannot determine exactly how difficult that will be. But we are obviously ensuring that all our plans are in place as best we can to prepare for the worst, and hopefully it won't be as bad as that. Now, within health and social care at the moment, there are many changes taking place once again, and this evolves around what is called the integrated care system. In our case, it is the North East and North Cumbria geographical area, and these changes will become fully operational on the 1st of April 2022. But at the moment, lots of developments are taking place with regard to its implementation. Now, fundamental to this integrated care system is what is called locality or place-based working. This is where local communities will work together to ensure that the people we serve are provided with the best services. And this means the National Health Service, local councils, the private and voluntary sector working together to ensure we maximise the resources we've got collectively. There'll be more about that as we go forward, but there is an opportunity, and this is the focal point of the annual general meeting, is item number 7, where there's an opportunity for any one of you to ask questions about the presentations that are given this evening, or what I've mentioned just now about the integrated care system. Our executive team, and particularly our Chief Executive, Sue Jakes, would be only too pleased to answer those questions. There's also a telephone line where people can phone in with questions during the meeting, and there is a question and answer box on the right of your screen that you can submit the questions. These will be collated, and Warren Edge, our Corporate Secretary, will read the questions out during item number 7, and they will be answered. If for any reason there's a question asked which we don't have the answer immediately for, they will be followed up with you after the meeting. Now, with the questions, we are only too pleased to answer any questions relating to our performance, relating to health and social care, and in particular our trusts generally. Obviously, what we won't do is answer any questions relating to specific patient care. We do have a patient experience team who can be contacted with either writing or by telephone, and they will follow up on your questions in that regard. So with that in mind, I'll now pass you over to our Chief Executive, Sue Jakes, who will take you through the next item on the agenda. So over to you, Sue.
Apologies for that. Thank you, Chair. So we've got some sound. Good. Thank you, Chair, and welcome to everybody this evening. I will try and take you through the brief that the Chairman's outlined. How accurately I can forecast exactly what's going to happen over the next 6 months, I'm unclear about, but on the basis that we are planning to ensure that we are well prepared for whatever winter holds, I'll certainly be able to give you an insight into that. So if you don't know us, we are one of the largest trusts in the country, and we serve a population of over 650,000. So we serve the biggest local community of any trust in the North East and North Cumbria, which forms the integrated care system that the Chairman alluded to. It's therefore not entirely surprising that we have over 2 million contacts with patients each and every year. We provide acute, emergency and planned hospital care. We provide health and wellbeing services, keeping people healthy and well in the communities. And we provide a huge range of community services. And I think the key to providing all of those things is the way that we integrate that so that we get the very best for every pound that's spent in our patch, working in conjunction with our local authorities. So as the chairman says, we probably couldn't last year, even at the AGM, have believed that we'd still be in the pandemic at this point. And interestingly, we're currently in what for us is really the 4th wave of COVID, and there's more of that to come later. I think as we began in April 2020, COVID had hit. We were in the grips of what had been declared a global pandemic. And whilst it clearly is something that we would rather we hadn't had to face, I think just to repeat some of what the chairman has said, the way that our teams, our staff, our communities, colleagues in local businesses came together, and with courage, determination, commitment and hard work shown by everybody within and out with the trust, we came together to really rise to the challenge of COVID and quite frankly modify things in a way that we couldn't have dreamt would be possible at the speed with which we were able to act. So we would like to pay credit to all of our partners, but particularly our staff and teams for their creativity, for their energy, for their commitment, and as always, that really strong focus around the patient. So if we move on to the next slide, what you'll see on here are some of the ways that our staff have represented how they felt during the pandemic. So I won't read those out, I won't read all of them out, but as you'll see at the top, they feel like we're a family. We do think that we are really close as Team CDDFT and really close with our partners and stakeholders. The heart that you've got in the middle of the screen there it's a word cloud that we went out after the first wave of COVID to ask teams and staff within the organisation, what did they feel summed up the way that we had responded? What were their feelings around COVID? And you'll see an absolutely inspiring set of words all wrapped together around that togetherness. As the chairman has said in his introductory remarks, I think that what we have found is that as the pandemic's gone on, and we'll be familiar with this from the news, it's got incredibly tough for our staff. So the fact that they are able to come together in the way that this slide depicts is truly amazing, and I think marks our team out from any other team in any other organisation, certainly that I know within the NHS. So as we move on to the next slide, you'll see that we've just pulled together a few bits and pieces because despite COVID, we managed to do an awful lot during 2021. Clearly, babies weren't waiting to be born. In fact, we saw some of our lists for those booking in to have maternity care with us increase as the number of COVID babies started to increase, not just in this particular area, but across the country. We're very proud of what our staff do, and it's been difficult with social distancing to do things in the same way as we have historically. So we were delighted to have a red carpet, a red curtain event in terms of our Virtual Star Awards. And as we got through the year, we found ourselves better able to manage technology and had a really great event celebrating some of the innovations and some of the committed, dedicated input that our teams had provided to patients right across the organisation. So that was great to be part of. There's been a lot this year on sustainability, and indeed the NHS has launched its own green plan, but not before we'd had a go at that. So we've got an incredibly inspiring group within the organisation who are so keen on this agenda and have found a huge amount of ways to impact already on our carbon footprint in the year 2021 and develop plans for the next 3 years. So we've got a commitment to carbon neutrality. We've got a very clear plan about what we're doing over the next 3 years. And in the year that we're reporting on, we did all sorts of things. So we were able to significantly reduce unnecessary travel through having and holding meetings in the way that we're doing this evening. We found ways to change the gases that we're using in anaesthetics in theatres, in pioneering work that's been copied across the North East and North Cumbria and wider, all with a view to making sure that we leave this planet in a better place for others. And we also know, and we're privileged to be working in the healthcare sector, that actually some of that carbon footprint actually damages people's health in the here and now. So everything we're doing on this agenda is helping both in the current times and for the generations that will come after us. We move on. Incredible support from our community. So what you have in these slides are pictures of our International Nurses Day and Day of the Midwife. We had to modify how they were done, but if you get a chance to have a look at the pictures in more detail, you'll see that we had incredible support from across our communities. Our schools sent in really inspiring artwork. We had all sorts of messages and thank you cards. We had our local MPs, the Lord Lieutenant, all writing in to appreciate exactly what our staff had done during the course of 2021. And of course, that continues now. We had some great support, and there's nothing like a good cake in the NHS. So we had some great support from local bakeries, and we tried to make and provide small treats to the teams of staff that work within the organisation, just to lift everybody's spirits right across the entire year. Moving across to the next slide. Just at the top there, that's a lovely picture of Margaret Amali, who actually joined our open board today. And it's there to just show that the appreciation we have of what diversity brings to the NHS and to healthcare. There's research from across the world that shows that if you can embrace diversity and engage well with a diverse range of staff, you actually can improve healthcare outcomes. So Margaret leads one of our groups that's looking at promoting that. We have 3 other groups across the organisation and a commitment to really ensuring that we seek and embrace diversity in every walk of the work that we do. We have teams that have learnt over the course of 2021 bits of science that was not known previously, as we've begun with very few tests for COVID and developed into tests that took quite a long time to process, right the way through to the very accurate tests that we can now do in our ED departments. We've also been participating in a lot of research, and that research has all been bundled up nationally and has influenced the way that COVID patients have been treated across our country as the year has rolled on. And of course, our allied health professionals, and a day to recognise exactly what they have done and what they contribute to the organisation. They were amazing throughout COVID. A lot of them got redeployed into all sorts of areas. They were working front of house. A lot of them were redeployed to work in respiratory areas when we were at the height of COVID, and were able to contribute really effectively to that and those team workings. We move on to the next slide. You'll see here one face that you might recognise. I'll come on to that last. But what we saw in COVID was the need to use PPE in a completely different way. As we began to understand COVID more, the arrangements for that became clearer and clearer. And I'm so proud to say that our procurement team ensured that we were never without the right personal protective equipment for staff at any point during the whole of that financial year, and that again continues. That's due to ingenuity. We had teams that were working literally across 7 days, but the supply of PPE, and you can see some of that in use in the pictures in front of you, was just phenomenal, as were the various products that we needed to enhance our cleaning regime. So we kept patients and staff safe at all points with exactly the equipment that they needed. The picture that I'll refer to just before I move on to the next slide is the one in the middle at the bottom. And for anyone who can't quite see that, that is Noel Scanlon, our Executive Director of Nursing, who's going to be speaking very shortly about the quality improvements we've made during the year. And it looks like some sort of torture that one of his colleague nurses is applying to him, but actually it was very important. I don't think everybody had heard of FFP3 masks until COVID, but this is an example of fit testing, and the team that were able to mobilise and fit test everybody who was coming into COVID areas at huge speed, and then people need to be fit tested for every single different FFP3 mask that exists. So as we were pursuing that challenge of ensuring that we were never without the relevant PPE, what it did mean at points was we had to change our FFP3 masks. So the teams that fit tested everybody did an amazing job, and that's Noel, who I think passed that particular test on that day. And several more thereafter. Several more thereafter, he's saying. So I think if we go on to the next slide, really, the chairman, and this statement is made in our annual report, which you can find on the website, and that goes into an awful lot more detail than we can this evening. But I think we share his view in how proud we were of our staff, our volunteers, our partners, other stakeholders, how with the ever increasing demands and pressures that came across 2021 and continue into this year, how everybody came together with that commitment, compassion and dedication that really marks out teams that work in and with Team CDDFT. As the chairman says, it's been a truly outstanding effort. We as a board take our hats off to everybody involved. We couldn't be prouder of the efforts that everybody put into that year and the year that we've now begun. At this point, I'm going to move over and give you a rest from my voice and let Noel take you through the quality and safety summary for 2021.
Thank you very much, Sue. So the quality and safety accounts was what we present at this point in the annual general meeting. It's just like the financial statement of accounts that will come a little bit later, except that the credits and debits relate to a series of quality and safety objectives we set ourselves at the start of the financial year. So clearly all of these objectives were put in place in March 2020 before the pandemic was declared. And we publish an interim plan. We review those objectives. We consult with patients, staff, stakeholders, council of governors, health board, various bodies, so those objectives are meaningful for our patients and actually demonstrate continuous improvement, which is what we're trying to deliver. You can see that we always tend to have a mixed picture, and the reason for that is that the targets we set are stretch targets. If it was green across the page, we really wouldn't be considering that we were pursuing excellence and we're delivering meaningful objectives that exhorted us to do even better than we would like conceivably achieve. So what does that look like in slightly more detail? Well, during the pandemic, it's worth mentioning that we nevertheless implemented a series of innovations in order to ensure that we delivered safe and effective care, notwithstanding the unprecedented pressures upon the service. And that meant that in real time, we reviewed every piece of national and professional guidance. We met as an executive each morning, and we implemented all of those safe practices to work safely. And much of that guidance changed very quickly as we learned more and more about the illness and began to implement the latest research and innovation in the field of COVID-19. There were ward audit programs that we monitored constantly to ensure that we had the right PPE, that people were pursuing safe infection control practices. And every single patient with COVID-19 was reviewed by every specialism each day to make sure that multidisciplinary care was of the highest order. One of the things that made the biggest difference was the 7-day matrix. We clearly didn't have enough to provide continuous clinical supervision and support to hard-pressed teams, but we recruited additional staff at a senior level, and that support, not just to nurses, but to doctors, made a huge difference in terms of ensuring that the right resources deliver the best care. That also meant that we contributed to research trials so that we played our part in delivering the latest treatments. And indeed, steroid therapy, which you may be aware of, was one of the studies that we became involved in. We also introduced virtual visiting for patients who couldn't have access to their loved ones while they were in hospital. And that meant that iPads were purchased, supported by our charity, and funded in part by those wonderful walks that Captain Tom did early in the pandemic that raised so much money. So what about our ambition? We wanted to improve the care of those with dementia and sepsis. We set stretch targets to reduce the incidence of falls. Pressure ulcers are seen as the single biggest indictment of poor quality nursing care, so we have a zero tolerance of those. And of course, we wanted to diminish or eradicate healthcare associated infections, which in the NHS means a zero tolerance of MRSA and continuous reductions of other statutory reported infections, such as Clostridium difficile. We didn't achieve all of those, but we did show continuous improvement. And we built on the full strategy we've had in place the last 3 years, and will embark on a new full strategy this year. So if you look at that chart of falls, you can see that the incidence mimics quite closely the prevalence of COVID-19 in the service. And that's because, of course, many of our hospital beds were filled with older patients with comorbid conditions who sadly were more likely to need to be hospitalised as a result of COVID-19. That is, those individuals are more likely to fall, sadly. They are higher on our risk charts, and they are being cared for in escalation beds sometimes by staff that were redeployed. And that made an impact, notwithstanding the huge amounts of pressure training and the reorganisation of our wards by mixing experienced staff with those that we redeployed from other areas. We then, as you can see, will begin to restore back to the baseline as the COVID waves dissipated. In relation to pressure ulcers, I mentioned our performance had improved, and you can see quite a marked improvement based on our performance in the previous 2 years. It's worth mentioning, however, that our pressure ulcer prevalence in County Durham and Darlington is in the top 2% of the country, and that is clearly something we want to build upon, but not be complacent about. In relation to healthcare associated infections, you can see that Clostridium difficile is diminishing in rates, but was nevertheless above the threshold that we set ourselves. And although the zero tolerance of MRSA was not achieved, the incidence halved compared to the previous year. If there are any GPs on the call, I'm sure they would agree with me that most doctors in the community are very, very interested in whether or not they receive discharge letters from the hospital so that they can effectively continue the care that we've started, or possibly we have managed while the patient has been more seriously ill. So the provision of discharge summaries is a very important target that we set for ourselves. And although we didn't reach 90%, we did reach 89%, which is quite encouraging. And that's something we want to continue to improve upon. And of course, providing the right care at the right time means that we continuously learn from all aspects of the care that we deliver. That means that we undertake mortality reviews of every death, where we identify themes in relation to some of the predisposing factors that lead sadly to mortality in hospital. We embark on campaigns, or we put in place innovations, including the development of acute kidney injury nurses, who were tasked with improving education and training in the detection of this very serious, but sometimes difficult to detect, complication of patients being admitted to hospital. We achieved our ambitions in relation to paediatrics, That meant that we were able to reinstate the front of house paediatric assessment area at the University Hospital of Durham following the first wave of the pandemic, and indeed extend its opening hours at weekends. We've made progress in relation to maternity standards, and we want to continually improve. Some of you will be aware the Ockenden review, which looked at maternity services at Shrewsbury and Telford, and made a number of recommendations across the entire NHS, including the introduction of something called continuity of care, which effectively means that every mother will be assigned a smaller number of community-based midwives to oversee and in some cases deliver them in the hospital. This is quite a radical step and requires huge amounts of investment, organisation and retraining. A&D, of course, has been under enormous pressure throughout the pandemic, and as you'll see from the next slide, I think it comes later, obviously. We did see improvements, but sadly that has not been sustained, and we didn't meet the 90% target that we had set. If we go on to look at the mortality indicators, you can see that in relation to most of those, we scored green, which indicates that our mortality rates are above or as well as good as the average trust in England. There's one indicator that is red. We are an outlier for something called SHIMI, which stands for Summary Hospital Mortality Indicator. Correction from Jeremy Kendall, sat across from me. Standardised Hospital Mortality Indicator. And one of the reasons we're an outlier in that is that everyone is an outlier in that. And this is a function of the pandemic, which we have been advised means that that indicator is not quite as relevant as it was before the pandemic. But it has meant that we've been able to invest in some areas where we expect to find considerable improvement. And that includes the acute kidney injury nurses that I mentioned earlier, but also a full complement of medical examiners. This is a new innovation across the service, which will mean that all deaths will be reviewed, and consequently, all bereaved relatives will receive some support and information about how their loved one passed away. We think this will be not just a significant improvement in terms of patient safety, in terms of learning for the service, but also in terms of the experience of bereaved relatives at a time when many people find it very difficult to cope with loss, not knowing perhaps exactly how their loved one may die. Next slide, please, John. In relation to maternity standards, you can see that 12-week bookings and smoking at delivery, we met the standard that was expected of ourselves. However, we set a stretch target of breastfeeding at delivery of 60%, and we were within 0.5% of that. So more to do, but nevertheless, these are important indicators that we are demonstrating improvement for our maternity population. I mentioned A&D waiting times earlier, and as you can see, at the beginning of the pandemic, we were above 95%, but that dissipated so that by the August of 2020, we were back down into the red before it started to pick up again from really quite a low position at the start of this calendar year. Unfortunately, that improvement has not been sustained, and it remains a significant pressure within the system. And I use the word system advisedly, because of course, A&D waiting times are not just a function of the performance of the hospital, but also performance of health and social care, and indeed primary care in managing patients who require emergency care, or possibly can be managed equally well through other agencies. And finally, I think we have a slide on patient experience. This relates to end-of-life care, which was hailed as an outstanding service by the Care Quality Commission when they inspected us in 2019. We also saw improvements in nutritional assessments, and that's very important because many patients become malnourished as a result of their illness or their admission to hospital. So consequently, it's very important that we assess their needs early and provide additional supplements or advice as it's required. I'm going to hand back to Sue now who's going to talk about the annual statement of accounts. Thank you, Sue.
Thank you. Thank you, Noel. So just in terms of those apologies that the Chairman went through early on in the meeting, we've also got apologies from David Brown. So I'm going to cover our financial performance. Essentially, we got a clean bill of health. So Mazars are our auditors. They did qualify our accounts as they did up and down the country, but only in so far as they were unable to obtain the audit evidence that they would ordinarily for the inventory balance at the end of the year. That's our stock take, and they were unable to do that because of COVID restrictions, they couldn't physically visit the site. So that aside, a good clean bill of health. They also reported on our consolidation schedules and that they were consistent with the audited financial statements. Another really important job that external auditors are required to do is advise if there are any issues with value for money arrangements, and they found that there were none. So that is almost as good as you can get. In terms of that financial performance, if we can move on to the next slide, you'll see that as a group, so the group consists of the Trust and SCL, which is our wholly owned subsidiary. We start with a deficit. Anyone who's eagle-eyed and has seen this in the annual report might see it's a slightly different figure. It's different just by 63k. So we do need to get the annual report reflected. This is the correct figure that you've got in the presentation. After a number of adjustments, the regulatory surplus, which is that we're measured on, was a healthy £1.181 million. That comma between the two ones should actually be a dot. If we had £1,181 million surplus, we wouldn't have to worry for an awful long time. So all those commas that you can see there should actually be dots. We changed an awful lot during the course of COVID in terms of the way that our services were operating. So a good example is the A&E department in Darlington, which we doubled in size essentially by re-providing outpatients elsewhere and taking over a big chunk of the outpatient estate. And we were able to do that, as I said earlier, at phenomenal speed, and we had really good teams working with us. What that meant is we did spend quite a bit on capital. So I think if we just press the button, another part of the slide will appear. And there it goes. You see the finance director's obviously been working overtime to get some fancy effects on the slides. So capital investment of 35.5 million, that is the most we've spent in a single year for a long time, considering there was not one big single project. So at the same time as we were running around dealing with all the COVID patients, changing our services, we were changing the environment, providing better technology, providing better physical space, and making huge investments in some of our diagnostic equipment and technologies to support our delivery of COVID services. So that was, I think, fairly remarkable. If we just press the button again on that, we'll also see our closing cash balance. Now, this is one not to get too excited about. So it's a lot higher than it was back in 1920, but most of this is to do with timing. So because of the pandemic, nationally, we received some of the money that we get monthly a little bit earlier, and some of the capital projects that we have spoken about, the cash outlay for those, usually you hold a little bit back at the end of a capital programme, have run between the years. So essentially it looks good, there's nothing to be worried in it, but a lot of it essentially is in the form of prepayments. So just to illustrate that for you, if we go on to the next slide. There we go. What you'll see is our income for 2021 was £70 million higher than in 1920. Now, if you get opportunity to look at that list, most of that is because we had additional costs as a result of COVID. So we had additional costs for testing, we had additional costs to buy all the PPE and equipment that we needed, we had additional costs when staff very kindly for forewent some of their holiday and were paid for that instead so that they could help out in wave one. So really that, in summary, was additional income that was provided by national arrangements that were put in place and is very similar to the expenditure and income changes that all trusts had. So if we move to the next slide, you'll see the expenditure slide, which is pretty much a match. And just for your assurance, we did undergo an audit. We were selected at random towards the middle of the year in question, and some of our expenditure was reviewed to ensure that the way that we had authorised it was appropriate, that we had the right controls in place. We're obviously then and now operating under a national pandemic, and there are various requirements, and we got a clean bill of health from that. So we have provided value for money. We've seen our costs increase. That's largely on the back of COVID, and those schedules detail that for you a little bit more. We're going to move on now to, I think it's a slide on questions, but if I may, I shall keep going and we'll take questions right at the end. So I'm now going to move us on to operational performance. So what you can see in the slide in front of you, if we move on, are the peaks of COVID. So these are the COVID numbers that we had in, and we've just colour coded them by age range. And what you'll see is we in 2021 had essentially 3 waves of COVID. That second bit of bar chart essentially has 2 peaks, and at their greatest we had around about 200 and I think it was 37 COVID patients in our trust. A ward in the trust is anything from 24 to 30 odd beds, so you'll understand that managing this activity was incredibly tricky from an operational point of view. Although, as Noel referred to, early on in wave 1, so back in April of 2020, what we did see is a lot of activity fall away. So people were not presenting who didn't have COVID. I think if we're all honest, a lot of people were frightened to come into hospital, even though we were encouraging them to do so where they had concerns. And at that point, across the country, a lot of elective services were suspended whilst provisions were made for dealing with what was very much an unknown at that juncture. If we move on to the next slide, this just gives you a flavour of what we were doing during the course of that year. So we had a system in place for ensuring that we had all of the necessary planning and governance. We were getting, in the early days, not so much guidance, but I remember one Sunday where we got 3 different bits of guidance on PPE use for application immediately the following day. So we were working across a 7-day week. We had people who really rose to that challenge, and we're grateful to everybody, particularly as we were all in the throes of wave 1 and things about the disease were just less certain, and we understood it less than we do now. We were able to introduce virtual meetings. We were able to change the physical estate at a really rapid pace, and we began very early to think about how did we support our workforce in the best way. So we ramped up the communication. We had daily bulletins from our gold meeting, which was the command meeting that we held within the trust each day, and that was so that partners, colleagues, particularly colleagues within the organisation, knew exactly what was going on. There was a lot of stuff in that year in the press, some of which was accurate, some of which was less so. So we had that continual touch point for staff, so they knew exactly what was happening and exactly the status of the trust, because as I've said before, we were able to keep a continual supply of PPE, but it was quite frightening for staff to hear on the news how in other countries and in places within the UK that was not the case. So we kept that information feed going and clearly listening right across that time. We introduced social distancing. all seems a long time ago now, and we then have had various arrangements around self-isolating, and because of the pressures on the main sites and the requirements of more space for social distancing, we introduced flexible working, so those that did not need to be in the organisation could work with all the technology and equipment they needed at home in arrangements that would be supportive of their well-being. So a summary of the operational changes, and some of these are, you know, changing even now. So patient visiting and some of the restrictions, Noel referred to the restrictions that we currently have earlier today. We are using our ethics committee to help now advise us on this, and patient visiting is something that we keep in under continual review. We have always allowed exceptions in specific circumstances because we recognise the importance of that for certain patients at certain points. Routine referrals, a lot of them were paused early doors because patients weren't attending their GPs with concerns, and so we had a drop in our activity for in terms of the numbers of referrals that were coming in, and a drop consequent in terms of our outpatient activity. As many of you will be aware, we've been encouraging people to attend those appointments, and we've now seen that return to post-pandemic levels, and clearly and unfortunately some of the people that are presenting now have got more advanced stages of their conditions as a result of not presenting earlier. Throughout the whole of the pandemic, we were really proud to be able to continue at all points with urgent and cancer activity. We separated pathways for COVID and non-COVID patients, so when we had a lot of people in the organisation, their paths did not cross once we were able to diagnose them. And actually we took patients for other trusts, so we took some patients for Cumbria Trust at a point where Cumbria wasn't able to cope with the amount of COVIDs that they had coming into their hospitals. We put escalation beds in place, and we were just so pleased with Bishop Auckland and how that came into its own in terms of the physical estate, and it also allowed us to have the increased use of the theatres that we'd upgraded some years previously. Some of our diagnostics were paused, but we continued with all urgent referrals, and we kept a really close eye on that guidance that Noel referred to, so that the minute that some of those restrictions were lifted in terms of national guidance, we reintroduced those diagnostics. And indeed, if we look at the position that we're now in, we at last count were leading on the elective and diagnostics the region in terms of some of our relative performance, about getting back to levels of activity comparable to those in 1920, which was before the pandemic began. If we move on, you'll see that even more COVID mitigations that we had in place, but we had an operational delivery group in order to begin to reset. So almost as soon as we were dealing with COVID, we were anticipating at what point we would be able to get on with some of the services that had to be paused whilst we were dealing with the increased numbers of COVID in wave 1. So the ODG, as we called it, began to look at that. We changed some of the services to allow them to allow the provision of more space on the main sites. We took chemotherapy off the main sites of Durham and Darlington and moved that to Shotley Bridge and to Bishop Auckland Hospital, and began to work through how would we keep patients safe and deliver elective care as soon as it was safe to do so, and essentially created elective services that are more discreet than they've ever been before from non-elective activity, because we have more control in testing those patients before they come in and knowing their status before they even arrive with us, a combination of testing and self-isolation. We managed to persuade our CCG, who was very amenable, to allow us to move into some of their office space at Sedgefield Community Hospital. So we turned that back into clinical space to allow us to have outpatients there in a dedicated space with plenty of parking, and again to create more space for COVID on the main sites. And with our emergency departments, we were looking to maximise the space that they had to operate in, and were particularly able to do that at Darlington in terms of taking over the outpatients departments. And this year we've been really pleased with the introduction of even more reconfigured space in Darlington to provide same-day emergency care, and the plan for that to move into new space in Durham is coming to fruition and will be in place before the end of this financial year. So some of those changes continue and really help us deliver as optimal performance as we're able to in terms of non-elective activity. So just looking, if we can, at the next slide. So urgent attendances did reduce initially, and some people wanted and preferred appointments by telephone, so we accommodated that from our urgent care sites. We saw emergency activity fall away, but as Noel's described, that's come back, and that largely accounts for the slide that Noel showed in terms of our performance against the 4 hours, because we had begun to see activity return, and indeed it's very pressured as we run through this summer. Again, you'll have heard this is a national issue, and for example, the attendances into emergency department at Durham are running at 13% higher than they did this August and September compared to 1920 before the pandemic began. So just a couple of additional things. We are lucky to have the community hospitals as well as Bishop Auckland. If we just move on to the next slide. So we've opened up beds on those sites, and those beds remain open now as we deal with the increasing numbers that we've been seeing in this financial year. And we were able to create additional ITU space using a ward at Durham and the recovery area in the new theatre block at Darlington. We've got and been on with staff flu vaccination. In fact, we got a letter in the financial year that we're reporting on for having the highest flu vaccination in the whole of the North East and Yorkshire, and we were credited with everything we'd done around that. And in January of 2021, we were lucky enough to have access to COVID vaccinations. So we began the whole vaccination programme and did that really, really effectively. And thanks to local authority colleagues, particularly in County Durham, who allowed us to continue with that as we provided that service to colleagues in social services from their main site just adjacent to the hospital. So if we move on to the next slide, this is referral to treatment. So as I've shared, we had to pause non-urgent referrals, but we were planning to restart elective activity as soon as possible and did not stand down urgent and cancer. What that has meant is that we've been reviewing cases. We review patients that are on the waiting list. We make sure that patients don't deteriorate and that we continually reassess them against 6 criteria that are determined nationally, so that we're dealing with patients in priority order. There were some instructions given to the independent sector that we availed ourselves fully of. So we were working with the Woodlands in Darlington and with the Washington up near Durham to increase the capacity that we were able to offer by utilising their services, which essentially had been commandeered by government. I've mentioned the outpatient services at Sedgefield, but we also put in place virtual appointments using technology so that we could begin consultations remotely where that was appropriate. We also worked regionally, so this is across the whole of the North East and North Cumbria, and we worked to ensure that anybody who was struggling with any urgent cases, any cancer cases, that we were able to accommodate those where that was appropriate in different organisations. So for example, we have undertaken cancer surgery on our sites for other trusts, and we recently had a routine ankle operation that was accommodated in a different trust for us. So we've very much come together as an NHS across the integrated care system, Chairman has outlined. We can move on. So unsurprisingly, the number of cases that we undertook in Q1 of that year when we were in the throes of wave 1 had fallen significantly. By the end of wave 2 and 3, which was Q4 of the year in question, our day case numbers were still down. But in the most recent activity that I've just seen, we were over 95% of the activity that we had done in the same period in 1920. This was for the period in September, so we had overachieved against national expectations, and it's that performance that I'm incredibly proud of in terms of the way that staff have been able to do that. And I think we made some really good calls early on, and Jeremy was very pivotal to that, our medical director, in the way that we have isolated our elective activity from other services. Cancer services, you'll see that we took a really proactive approach. So we continued to provide cancer services, but we reached out in a different way to provide advice and reassurance by telephone to anyone on a cancer pathway during COVID, recognising that it was quite a scary time for a lot of people who were unsure and were hearing on national news significantly that there were problems in terms of people being able to access those services in other parts of the country. We were also able to introduce some novel ways of dealing with things, some of the diagnostics that lead to a cancer diagnosis or otherwise in a different way. So colon capsule endoscopy went live in March. So that's a relatively non-invasive way of checking for certain cancers. We were able to have different prehabilitation clips to ensure that people who were needing cancer care came into our organisation for that care in the best possible way to have the best possible outcome. And we've recently been introducing some of the volunteers that we work very closely with in terms of particularly Macmillan. At the top of the slide, you'll note that we were a finalist in the 2020 Health Service Journal Award, and this was a real innovation. Skin cancer is significantly increasing across the country. It's been in that position for years. There aren't enough dermatologists, and we use technology to allow us to triage and allow a pathway that began on a straight to test pathway from early in 2020 that's proven to be very successful. So as we think more into the future, and I've given you bits of glimpses in terms of where we are now, if we just move on to the next slide, if we could, that's great. So we've got slightly less than 90 COVID patients in the trust as of today, but we have got unprecedented demand. Teams are, as you will appreciate, really quite tired. They've been at this for a long time. We're continually reviewing and enhancing the wellbeing offering that we have. It's the least that we can do given everything that every member of staff, whether they're working directly with patients or supporting that work from elsewhere, everybody has pulled together in an amazing way. But I think it's probably worth just touching on what we're doing at a macro level. So never before has it been clearer that the NHS is at its best when it works together. There have been periods in the NHS's history where we've almost been encouraged to be competitive, but COVID has shown us the benefits of working across organisations for the benefits of patients, and I've given you some examples. So as we go into winter, we think it's going to be fairly tough. All of the forecasts suggest that, and what we are doing is we're putting things in place that allow us to spread that pressure appropriately to where it can best be dealt with. and in doing so, we are looking at that from also at a more local level. The chairman mentioned the localities that we work within. We're working very closely, for example, with our GPs at looking at what we can do to manage demand at the front end. In fact, some of our GPs have been in just this weekend to help look at what the potential is for them taking some of the strain from the front end of our ED departments to try and get that demand back down to manageable levels. We've also got a big communication campaign, which you'll be seeing more of. Do Your Bit is something that we introduced last year and will continue into this year. But I think in summary, without having the time to go into infinite detail, the way that we come across the health service family within the North East and North Cumbria will be the signal or the marker of our success. We are working very closely with other providers. We formed a collaborative and that is bearing fruit already. So a lot happening internally within the trust, great staff within the trust, and that appreciation of collaborating to ensure that everybody who lives in the North East and North Cumbria gets the very best in healthcare. Warren.
Right, thank you, Sue. As a foundation trust, we are of course accountable to our stakeholders, especially our patients, the public, and to our staff. And we're made accountable through our membership, which comprises the public membership shown on this slide, our staff, and through the governors who our members elect to represent them. I'm going to say a little bit in these next few slides about how we've sought to maintain and engage a vibrant membership and the role of our Council of Governors, which clearly in the midst of the pandemic, with social distancing, virtual working, has been more challenging in this year than in many others. We have, as you can see, 11,200 members. So we've held the position over the course of the year. We do occasionally get people that leave when we find that they've left the area in response to mailings. We usually would see a much higher number of new members in any pre-pandemic year, shall I say, where we've been able to get out and do more face-to-face recruitment. Next slide, please, Joanna. The breakdown of that membership across our various constituencies tends, as you can see if you glance down this slide, to follow the main population centres, with a little bit of slight bias towards Darlington and also to Wear Valley and Teesdale. The geographic profile has been pretty static over the last 3 or 4 years, even though we have maintained and actually, if we go back several years, increased our membership. But one of the things that I'm really quite proud of in terms of what we've done over the last 3 to 4 years is in doubling the size of our younger membership, under 25-year-olds. And that's a growing cohort of people that use our services. It's very important that we have their voice. And we've done that, working very much with further education colleges and similar organisations. And we've been able to maintain some of that even virtually over the last year. So my thanks to them for working with us and from my team to adapting their recruitment approach to a virtual world. Next slide, please. As I said, what we want is a vibrant membership that we can engage with. We do want growth in numbers. That is, for me, less important than being able to interact with our members and our governors and to hear their voice in planning our services and taking feedback on our services. So engagement is slightly more important than growth in numbers. We want to grow numbers, and we're learning slowly how to adapt to do that in a world where we need to do much more of it virtually. For much of the time, we have been reliant on more passive recruitment methods, so advertising through TV screens in outpatients, through our website, through social media, etc. We have managed to do some virtual activity of the type I've outlined with further education colleges. And in the last sort of 6 months or so, we've started to do some work using virtual platforms to engage the public with our commissioners through their reference groups, and with Health Watch as well. It helped us to reach members of the public to take their views as we are in the midst of revising our quality strategy. We intend to develop some constituency-based communications. Again, these will be virtual, in reaching members in different areas. We know that the issues are different for different localities, so we think that's a good way to give members a voice to communicate with us. We've knitted that together in a refreshed membership engagement strategy, and the Council of Governors Audit and Governance Committee will be given oversight of that in terms of how we take it forward. We are now looking at the potential for outreach engagement in a socially distanced and safe way, a COVID safe way. That's early days, but clearly a priority for us over the remainder of this year. Next slide, please. In terms of the elections that we use in the year, I think really what I would encourage anyone who's interested in becoming a governor to take from this slide is that actually we do have a reasonable amount of turnover, because all the seats last for only 3 years. And if you count up the number of elections, the number of seats on this slide, then I think there's actually, hopefully no one's superstitious, 13. We have 39 seats as a whole, 20 public seats, 9 representing staff and 10 appointed by our various stakeholder organisations. And our turnout is fairly typical for this type of election. Next slide, please. Despite the fact that we've been working virtually, and despite the fact that we haven't been able to hold physical meetings for our Council of Governors and the committees that the Council has in place, I'm really proud of the fact, because I do know that we have achieved more in this field than in certain other organisations. That working in a virtual way, we've managed to run all our Council of Governors meetings during the last year and on into this year, and managed to maintain the majority of the subcommittee meetings as well. So that accountability through our non-executive directors and more widely through the senior leadership of the Trust to our governors, we have been able to maintain. They have been able to scrutinise, ask questions, oversee our response to COVID and our restoration of activity. We make it very real in terms of that accountability line. So our governors appoint our non-executive directors and take part actively, both by giving feedback, but also as part of the groups that undertake appraisals, and the appraisal of the chairman and the non-executive directors. Governors are able to observe virtually, of course, board and board subcommittee meetings, depending on, in the case of board meetings, the public parts of those meetings. And where we have made such changes in response to COVID and for other reasons, our governors have been able to scrutinise and ask questions around that. So we're very keen that we continue to give governors a real voice in influencing our services. And I'm very keen that if anyone is out there watching tonight who is not yet a member or is not yet a governor but would be interested, that you pursue that, please. And please don't take my word for how active our governors are and what they're able to contribute. I'm delighted that tonight we also have with us our lead governor, Catherine Featherstone, who no doubt can say from her perspective in a few words the value that governors add. Catherine.
Thank you, Warren. I think I would say that the governors have worked over the last year to support the Trust in what have been very difficult circumstances. And we have engaged via Zoom and Teams, and indeed the phrase of the year has been "you're still on mute," to actually help ensure that the services that are being provided safely, and that our NHS staff are supported through what have been very trying times. We have pushed the public agenda around restarting services as soon as it is safe. We've certainly held the non-executives to account for the effective and safe performance of the Trust. We've particularly raised concerns about making sure that patients are safe with the problem with the water at Darlington, and encouraged the Trust to make sure that services continue to be provided from Shotley Bridge. And I think we've all been so incredibly impressed at how well all of the staff have worked and continue to work in very, very trying circumstances, and at the support that the executive have put together to support our staff, and we've certainly been encouraging the trust to do that. So I think, speaking as a governor, there are a lot of things that you can do to help improve services and to help improve care of patients and staff, and I would certainly encourage you to get involved at all if you can. Thank you, Warren.
I think it's now back to me, is it, Gillian? Hello?
Apologies, Chairman, back to you.
Yeah, okay, thanks, Gillian. Well, thanks to colleagues for those presentations, and thanks to Catherine, our lead governor, for giving her perspective on how governor engagement is so important to the success of our trust. Item number 7, I said at the very beginning of the meeting, is a very, very important part of our agenda. We take every opportunity to listen to members of the public, to our patients and to our governors. So in this part, Catherine has already submitted some questions to Warren, which Warren will read out, and our execs will answer them accordingly. I'm not sure if we got any questions through the telephone line or through the question forum, but if I could pass it to you, Warren, to take each of the questions you've got by whatever means, and our execs will respond to them accordingly.
Okay. Yes, thank you, Paul. I'm getting an echo from somewhere. Yeah, thank you, Paul. So Catherine has, in her role as lead governor, canvassed some views and given some thought to certain matters of real importance to our members at the moment, and has therefore forwarded 4 questions for response from the executive directors tonight. So the first of those questions I'm going to direct to our Workforce and Organisation Development Director, Morven Smith, because it does concern and builds on some of the things that Sue has said in terms of supporting staff. So how are we supporting staff to manage a heavy workload and cope with changes in working patterns and avoiding burnout?
Thank you, Warren. Yes, as you've heard throughout the presentation this evening, clearly that's been a priority for us as an organisation to provide that support to all members of Team CDDFT. We've highlighted some of the high level interventions and the priorities and the focus around recruitment, retention, agile working, making sure that staff can take annual leave and feeling supported in getting to and from work and being protected whilst at work. In addition, there's been a number, and I've got a very long list of some of the specifics that we've put in place, because clearly both throughout the COVID initial waves, there was significant focus on providing health and wellbeing support resources, both nationally and locally. So to name a few, we referenced the Health and Wellbeing Resilience Hub that was provided across the region and presented a number of apps that you could access online around mental health support. There was coaching, there was counselling and access to psychology support. That was provided through our mental health trust partners and was very well received. We've got our own psychology support through our own occupational health services, and they too have been instrumental in informing and influencing some of the responses that we've had locally. We've got TRIM practitioners, which is a trauma risk management, which was part of some funding we were afforded towards the end of last year. That meant that we could recruit and train to 50 TRIM practitioners internally to the organisation. They are continuing to be supported and are now actively being used through the continuing demands on the services and the ongoing pressures that the staff are working under. So that has been a very strong and positive investment into our staff welfare. We, in addition, have wellbeing conversations. They take place with each individual. We're building those in on an ongoing basis to part of our performance review processes, but clearly can take place at any time. And we've also engaged in comprehensive risk assessments, making sure that we've prioritised various categories of staff, including clinically extremely vulnerable staff, clinically vulnerable staff, staff that fall within all the key protected characteristics that might have been exposed to specific risks throughout COVID, and then to our total population of staff on an ongoing basis to ensure that they are adequately supported and provided for through adjustments at work if necessary. You've also heard a reference to our network groups through the Equality, Diversity, Inclusivity. They provide access to staff with particular concerns. We've had numerous training that we've invested in. We've got mental health at work training for managers. We've got training support for managing stress in others. So all of these have been initiated throughout the course of the last year. And obviously there is resilience training ongoing, which has been provided to staff for some time, but clearly has taken on a new priority, new focus. There is a very comprehensive communications and engagement strategy and campaign which maintains that support and that reiteration of access to all of these services, and that will continue to be crucial to make sure that our staff continue to get signposts to the services that they need to access in a timely manner. And then obviously it would be remiss of me not to highlight, as Sue referenced in her presentation, the role of occupational health services throughout the course of last year, who responded very, very quickly to all the various challenges and directives and guidance that were forthcoming, and strove to provide that reassurance to our staff that they were being safely protected at work and in the various areas of concern that they may have. So I could go on because the list is extremely comprehensive, but hopefully that provides some assurance about the depth and breadth of response that we have put in place and continue to put in place, because clearly, as you've heard, the pressures are being maintained and are continuing over a much longer period than we would have hoped that we would have had to respond to. Thank you.
Thank you, Morven. The second question that Catherine's put forward on behalf of governors and members concerns something I think you heard her mention previously, which is the water supply at Darlington Memorial, where we are undertaking works to maintain the quality of that supply and indeed to improve it for the future, and where we have issued press briefings in terms of that particular work. So I'll pass over to Noel, back to Noel Scanlon, for an update in relation to that work. Thanks, Noel.
However, that has resulted in some difficulties in relation to the amount of pressure that, I'll have to look at this as well. I'm just talking to myself before. You can actually see me now. So the way that we're controlling Legionella is to provide chemicals into the system. That is only partially effective. The other approach is through control of temperature of the water supply, and then finally through end of the line filters, which are applied to all of the water outlets. Now those filters unfortunately have the consequence of reducing the pressure coming out of the taps. This is a significant problem at the top floors of our hospital, and consequently what we've had to do in recent weeks is to install further pumps so that we can restore supply and pressure, so that women, particularly on the 6th floor, can have a shower after childbirth or gynecology surgery. I'm very pleased to say that scheme is now complete, and indeed just last week I received a terrific WhatsApp video of a free-flowing shower on the 6th floor, which I have to say I was very heartened with. So we've restored the showers on the 6th floor. The point of use filters are still in place, and I'm also pleased to say that we've changed our water supply. So up until quite recently, we received inflow water supplied from Northumbria Water. We've now reinstigated the borehole, which means we're taking water from ground temperature, which is much cooler than from the mains, which is an ambient air temperature, which means that we expect the Legionella levels to fall slightly and certainly achieve some measure of control that we haven't really managed to attain thus far. That being said, we've had no outbreaks of Legionnaire's disease whatsoever as a result of the terminal filters and the other mitigations we've put in place. We're looking at our current regimes of chemical dosing and probably changing the disinfectant agent that we're currently using from hydrogen peroxide to a chlorine-based chemical. Now, all of this means that the water supply is under constant monitoring. We're receiving fantastic advice from our external water safety engineer under the supervision of Public Health England and Darlington Borough Council's Public Health Department. So we are seeing some measurable improvement. That being said, the underlying issue is our water tanks, which is an enormous scheme to replace. That scheme won't begin until March. It's currently in the design and tender stage, and that will be a 6-month scheme. So we won't be able to completely control the situation probably for another year. But at the present moment in time, we've at least ameliorated some of the unfortunate impacts on the patient's experience, particularly that we saw on the 6th floor. Thank you.
Okay, thank you, Noel. The next question I'm going to put to Sue, which is how are we planning to catch up with referrals, routine operations and cancer treatments?
Thanks, Warren. I think I've probably touched on aspects of this in the presentation. So we're doing it in a number of different ways. First of all, we have appointed somebody to manage this specifically within the organisation until we get back to where we were in 1920. So we've given it additional management focus, and there's a series of arrangements that are happening within the trust so that we're optimising at all points on all aspects of the elective activity pathways, our ability to show or to undertake the highest possible number of procedures. As I've shared, that so far looks as if we're performing very strongly, and we have been ranking within the North East and North Cumbria at the top on a rolling 4-week basis. I think that's largely, as I referred to before, down to the decisions we took earlier on in the pandemic to completely separate our pure elective activity out from everything else and keep that protected. And have the testing and the isolation regime that I referred to. But we're also using the independent sector. We're also over the guidance at all points. So when that guidance is changed in any way, we're there and we're making changes to allow our capacity to increase. In fact, people will perhaps recall earlier this week there was a news release around some changes to IPC, infection prevention control, and the social distancing guidance aimed particularly at ensuring that hospitals could deal safely with a maximum optimal amount of elective patients, and pretty much we, with our internal arrangements, were already in the position that was being outlined in that guidance. So that shows that we have tried to be progressive. As I've also referred to, we are working collaboratively. So if we have particular pinch points and there's capacity elsewhere in the region, in either private sector or NHS, we are, where patients wish to, allowing patients to move. I think the sort of sad reality is it's going to take a bit of time for everybody to get back to waiting list sizes that existed before COVID. So recognising that, as well as continually undertaking clinical reviews of the patients on the waiting list, we're also pioneering an initiative that's being run across the Northeast, which is to keep people well whilst they're waiting. So if you're waiting for a joint replacement and you're in a level of pain, there are things that you can do to keep yourself in an optimal condition for having that operation once it's available to you. So we're ensuring that patients have access to that so that they are well whilst they wait and therefore have an optimal outcome following their surgery. I shall stop at that point. Thank you, Warren.
Okay, thanks, Sue. So the last question from Catherine, which I know is something that will be dear to many people's hearts. There's another one for Noel on camera 2, please, Noel, which is what are our plans to restore visiting or increase visiting for patients?
Thank you for that, Warren. Like most trusts in the country, we suspended visiting for quite a long time. Visiting is clearly a concern at the present time while COVID-19 levels are so high. In Durham and Darlington, instances over 350 per 100,000 population. In addition to which, as Sue pointed out earlier, we have 82 patients in our hospitals with COVID-19 and a further 10 outbreaks of transmissible infection, that is to say, transmission between patients that we would like to have avoided. And that's clearly a huge concern. And indeed, in the past, we have had outbreaks of COVID-19 that have been mediated by visitors. So we are currently not minded to reintroduce visiting very, very soon. That being said, there are exemptions to the current visiting suspension, and they relate to patients at the end of life. They relate to patients with learning disability or autism, with dementia, or with some mental health issues, and indeed for children who have resident parents. And there are some special rules that we have around the maternity population where antenatal scanning, we do allow some visiting, but under some controls in relation to lateral flow testing and of course birthing partners. So we would quite like to move back to a position whereby we can reintroduce visiting safely. That may require some examination of vaccination and lateral flow testing, but we do recognise that visiting has a huge benefit to patients, not least advocating for them when they're feeling ill, assisting our own staff in planning discharge more effectively, not least also allaying the anxieties of relatives who can't see patients for themselves and worry about them greatly, not in addition to which, of course, patients feel isolated and alone. So removing visiting is a step that we've had to take very reluctantly. We do review our visiting status all the time, and I'd like to be able to bring forward some recommendations to change our current position as soon as we possibly can. Thank you, Warren.
Okay, thank you, Noel. So we have been monitoring the question and answer facility through the live event software as the meetings proceeded. And we've also had one of my team manning a telephone, but we haven't actually received any questions through either of those channels. So that would conclude public question time, because before I do, I am aware that we do have typically quite a number of members, governors, etc., who may view this recording when it's published after the event, sometime after, and that they may have questions that come to mind. So I'd just like to remind people that the Trust does have an inquiries mailbox that you can find on our website, and at the back of the annual report there's also the address for the Foundation Trust Office to my team. If anyone did have a question watching this in the recorded version or in going through the annual report, you can still email us and indeed ask that question, and we will do our best to respond. Thank you.
Thank you, Warren. Just said, obviously, there's a lot of information imparted this evening. Fundamental part of everything we do is about communicating to our staff and to the public about how we're performing and what we are doing. So I'll start with the communication team. There's a bit of an echo, so I presume everybody can hear me. Yeah. Well, to thank the communication team for everything they do. Clearly, we've increased our communication methods significantly over recent years, using everything from social media to working with the local press and all concerned to ensure that people know how our trust is performing and what we're doing. Now, a great example of this, obviously reference has been made to our Council of Governors, and we are very privileged in having a great group of Council of Governors who take their role very significantly. As Warren has mentioned earlier on, the meetings have been held virtually, but one of the best attendances we had at our Council of Governors meetings was the last one. So moving forward, we will now be considering using the hybrid method of communication, whereby we will use the virtual and the physical component at our meetings. So that's been a great learning example about moving forward. But I'd like to record my thanks to Gillian and her team for the exceptional work they do in promoting the organisation and communicating so effectively. Now, underneath Gillian's team is our charity, and Noel has made reference to our charity and how instrumental that has been in supporting our staff and our services over the last 18 months and ongoing. And the amount of resources they have collated and generated for our organisation has just been absolutely significant. And I would again want to put on record our thanks to the public at large, and that included individuals, schools, organisations, other charities and so forth, catering organisations who have supplied so much resources to our staff and still happening. So all of that is very, very much appreciated in terms of supporting staff and the organisation at large. Sue has mentioned about partnerships and the collaboration. We have a clear philosophy about how we work as an organisation, and that is working with partners in every aspect of the health and social care sector, because clearly we have a commitment to ensuring that wherever we can enhance the quality of care, whether it's in our hospitals or in the communities, we will do that in collaboration with all concerned, and that will continue throughout. Now, Noel has made reference to our staff, and I did so at the beginning of the meeting, and thanking them for, the commitment, the compassion and their goodwill in terms of supporting our patients throughout very, very difficult times. And again, obviously we're still going through these very challenging times. So again, our thanks to each and every one of our staff, our volunteers, our partners in the health and social care sector for everything they do in protecting our public. Now within that, and I would like to ask, clearly there are times where our staff experience some challenges from individuals who visit our organisations. Those challenges are sometimes unwarranted, disrespectful and so forth. So I would just ask everybody to be just patient, respectful and just acknowledge the difficult times that our staff are having to put up with and dealing with the increased demand and activity that Sue and her colleagues have outlined this evening. Again, we have a board which you've heard from some of the executives this evening, but we're very fortunate in having a board who is really committed to enhancing the quality of patient care. Fundamental to everything we do is the patient and the patient experience, whether that patient is in one of our hospitals or in the community. It's their experience that matters to us. And if you ever get the opportunity to attend one of our open board meetings and see how that scrutiny takes place between the non-executives and the executives in actually ensuring that everything we do is fundamental to improving the quality of patient care. So just to conclude, I, as chairman of the trust, is extremely proud of our organisation and everything we do, and every member of staff that works with us or for us or in the community, wherever they are, I'm just really proud of everything they do. But as an organisation, we are not complacent. We don't sit on our laurels and think that everything is going perfectly. because the demands on our service are increasing time and time again, and we will take every opportunity to improve the quality of our services. So the public have a role to play in liaising with us, and as Warren mentioned, if people have got any questions they thought about during this evening's annual general meeting or when they get home, then please put those questions into us and we will respond to them. So this evening I would just like to thank everybody for being present and hope everybody has a very successful, enjoyable evening, and I look forward to the time when we can have a physical meeting and have a proper exchange, a one-to-one, hopefully this time next year. I said that last year, we didn't realise it, but hopefully this time next year we'll be able to do that. So thank you to each and every one of the presenters this evening, and thank you all for a very good annual general meeting. Thank you.